Good morning, everyone.
Good morning.
Welcome to Pediatric Grand Rounds on this lovely Thursday morning. It's my pleasure to welcome Dr. Cesar from the Department of Orthopedic Surgery, Associate Professor of Orthopedics at Virginia Tech Carilion School of Medicine. Dr. Bravo specializes in the treatment of hand and upper extremity surgery and completed a fellowship at the Mayo Clinic in Rochester in this specialty. In addition to his many responsibilities in teaching of residents, students, and physician assistant students in didactics and clinical settings for the last 17 years, he has organized the hand surgery educational curriculum for the orthopedic department at Carilion, Virginia Tech. He is the founder and currently the program director of the Virginia Tech Carilion Hand Surgery Fellowship. In addition, he collaborates with the Mechanical Educational Department of Virginia Tech and is part of the team that developed the exoskeleton prosthetic mechanical glove for patients with brachial plexus injuries. Development of this device provided the patient's ability to gain hand function. In addition, he collaborates with his colleagues in the hand and upper extremity surgery division at Carilion Clinic in 2 randomized clinical trials that have modified how we manage post-op pain for patients undergoing minor hand surgical procedures and understanding when patients are able to safely drive after hand surgery. He's married for 25 years with 5 lovely children and has been in the Roanoke Valley for 17 years. Please join me in welcoming Dr. Cesar Bravo.
Well, good morning to everybody, and thank you for the invite. It's definitely an honor, and this is a beautiful facility. You guys should be proud. Hopefully we can join in orthopedics and contribute and collaborate with you guys. The topic we're covering today is pediatric hand surgeries, and there's a lot that you could cover, and this is a topic I'm passionate about, so I really love it. But hopefully what the goal is to provide an update and kind of create a foundation that then years to come we can always come and provide the update with regards to hand upper extremity injuries in the pediatric population. So we'll try to cover a lot of points, but just the salient points, but enough that at least we pick up something and just kind of review what we normally would see in our dated in practice in pediatric hand in the pediatrician's office as well, and what to refer and not to refer in a sense. So hopefully it's very helpful, and then any feedback, definitely we would love it. That's how we get better, and thank you again for the invite. So I do not have any conflicts of interest to declare. And one of the objectives that we're going to try to cover today, we're going to review the current hand examination of the injured hand. For our fellows or residents, this is something that's very important, especially in the pediatric population, that really a lot of things can be missed. We want to understand the 5 common subtypes of the Salter-Harris classification for pediatric fractures, how that kind of applies to the hand. Identify common pediatric hand finger injuries, not to miss, something we see in our day-to-day practice and that you guys will see in your day-to-day practice, and that's just things to identify. And then apply early treatment, timely referral, because we want to avoid, the goal is avoid long-term sequelae, including chronic pain, decreased range of motion of the digits, and post-traumatic arthritis. To start, the pediatric hand exam is just assessment of these injuries can be challenging in the pediatric population. The injury might be, it's different than the adult trauma because the difference of the mechanisms of injury, usually the presence of open physis and the patient's complying in some cases. So we always tell patients the pediatric hand exam is different than the adult exam, even though they have a lot of things that are very similar. We tell our patients, our residents, that basically when we examine the pediatric patient and the pediatric hand, you have to individualize the treatment. In the children, the age of the child is everything. We know from small patients, from 0 to 3 years old, they will not participate. So these are the ones that they will stay in a well-padded cast. Younger patients from 4 to 10 will kind of participate, but they can't help being kids, and they'll play with the cast or play in the cast and to put things within the cast. Older patients, 11 to 18, they'll participate, but usually these are the ones that are not as compliant. They tend to break the rules. These are the ones that end up taking their cast off. So you really have to individualize your patient and kind of assess what you're dealing with this subtype population. And teaching points is that the adult techniques are not necessarily in hand surgery are not applied to kids. And one thing for sure is kids don't have to go back to work, so we can kind of restrict them a little longer, and they should have a full-time caregiver with them. So those are things that can apply and kind of manage how we kind of immobilize these patients and treat. So the goals, basically what we want to do is delay basically make sure that appropriate treatment is not delayed, because this would carry out basically a long-term morbidity. The window of intervention in children is definitely shorter than in adults, so owing to the faster rates of healing. So whatever we do initially does have long-term sequelae, and it can happen pretty quickly. And the pediatrician's role is critical in identifying this and these referrals and kind of identifying these injuries, because you guys are the frontline people that see these patients, the physicians that assess these injuries, that are not always coming to the orthopedic office, to orthopedic and upper extremity specialists. What happens with delayed hand care? Things that we tend to see is it leads to infections. From these traumas that are missed, we see poor outcomes, poor function. They can lead to non-unions, malunions. And the worsening problem can lead, if they have soft tissue injuries, they can have necrotic tissue, and this leads to a complex sequela that's very difficult to manage. Nerve injuries, very important for us to see them early, because if those are missed or not treated, you have worse outcome and inadequate repair. And then, there's a lot of things that can be avoided early on and treated accordingly. So for the pediatric exam, and a lot of this is review for you guys, the child's hand dominance should be documented. Normally develops around age 3. The information about the child's activities, sports, music, career goals might be relevant in older children. Always we look for tennis update, and that should be elicited and updated. Just because of open injuries, different things, it's very important to document all this, and you guys do this, so I know this is all review. Developmental history of previous hand injuries should be garnered as well as to provide you in your exam. And the possibility of non-accidental injury should always be entertained. Not necessarily in the hand, but then when you start seeing proximal humerus, middle third clavicle fractures. Those are things that in the upper extremity, it should be a sign that for us to consider and think about that, and always have that in the back of our mind as we're examining these patients. Essential injury questions that we tell our residents or fellows when they're examining the pediatric hand is, when did this injury occur? What was the mechanism of injury? Is there any numbness in the hand? And has this been previously treated? Because a lot of times we're seeing them second or third, fourth time after they've been already evaluated. And that makes a difference, because then it kind of tells us how long ago that injury was and how delayed treatment has kind of come into effect. And if it was manipulated or the procedures performed, and those are things for us to ask. In the exam in general, it's like any other physical exam. For our patients, you want to do a good inspection, and especially note the finger creases. It's very important in the hand, in the pediatric hand. Tenderness, swelling, bruising, deformity, wounds. You want to document for motion, because you can have scissoring if you have fractures that are mal-rotated. So when you make a fist, the fingers will kind of overlap each other, and you want the fingers, when you make a fist, to kind of point into what we call the scaphoid tubercle right here. And look for perfusion, neurovascular exam, and cessation, and we'll kind of show some pictures to kind of help with that part of the exam. So here is just a top of a graphical view, or basically a picture of the dorsal aspect of a pediatric hand. This is my 10-year-old, and this is the volar aspect. So here in the area A, and this is the anatomical snuff box, and this is right here, and that's between the first and second extensor compartment. That's where we feel when we have pain for scaphoid injuries. This on this portion right here, it's the distal radius metaphysis, and this is the ulnar styloid. And if you look at the palmar aspect, you're going to have your pisiform, your scaphoid tubercle, and also if you kind of follow a line from here, that's the hook of the hamate, that sometimes you'll have those wrist injuries. And then here, the A1 pulley for trigger thumb that you can actually see. And if you look, very importantly here, looking at these creases, I don't know if you guys can see my arrow. Can you guys see my arrow? So these creases are very important, because if they don't have creases, you can have swelling, and some people have, or some pediatric patients may have absent creases, and that may be something that is congenital, and they may not have motion in that joint anyways. And those are things to look at. Also in the pediatric patient population, we have these dimples right here. These dimples are very important because they actually localize your metacarpophalangeal joint. And in pediatric patients, in the very younger patients, because of the adipose tissue, the congenital hand, basically the pediatric hand has a lot of padding, and sometimes you can't see those creases. And those dimples actually are very common that we cannot see in a baby, and they localize the metacarpal familiar joint. And those are important salient points with that. And again, looking at the creases, and just remember that this crease right here, we call it the proximal digital palmar crease. It's not at the metacarpal level, it's at the base of the proximal phalanx. So you'll see these fractures that we talk about, phalangeal-based injuries or phalangeal fractures. That's where they'll have the pain, and that's where they'll have bruising and swelling. And anytime we see bruising and swelling and inspection, that's a high, basically red flag for us that more likely there's enough of an injury that we think there's fracture until proven otherwise. And one of the things with the pediatric SAM is something we use in adult that does apply to the pediatric population. It's called the tenodesis effect. And this is very important because we can actually determine tendon continuity independent of nerve or muscle function, meaning that when you extend your wrist, you flex your hand, and when you flex your wrist, you extend your digits. So with intact tendons, the passive extension and flexion of the wrist will result in compensatory finger flexion and extension. And this is what we're talking about. And that, let's say you have a nerve palsy, so they're not have a radial nerve issue. They're not able to extend their digits. You do a tenodesis, they all have a tenodesis because the tendons are connected. And this is something that is easily done and complements, and you can kind of decipher and helps with the clinical exam. And patients, you can have them play, and with play, they'll do the tenodesis, and you can actually see with our pediatric patients. Vascularity can be assessed by color, temperature, and capillary refill. And one of the things that we talk about is anhydrosis, which is basically not being able to sweat or the dry skin. Usually we tend to see dry skin with nerve injuries. Usually we have some kind of glabrous, kind of moist skin or sweating. When you lack that, we think of sensory nerve injury or a digital nerve injury. And the lack of skin wrinkling, which is what we call with the submersion water test or the warm water immersion test, suggests basically that a nerve has been transected. And we use this in our clinics. And this is an example of a 4-year-old that had a laceration right here. And you can see it was immersed in warm water. You can see the wrinkling effect on the ring finger, but you can see there's no wrinkling here in this portion of the digital nerve of the small finger. And likewise, this was the injury the patient had. And you can see that the digital nerve was transected. This was what was done, was repaired. And if you can see, once the nerve recovered, we did the immersion test, and you can see the wrinkling again reestablished. So those sensory connections of the afferent sensory connection, when it's disrupted, we don't have this autonomic response. So we use this, and this is an easy thing that patients will do. They'll think you're playing, and we can actually do it, and we're not actually trying to do two-point discrimination, monofilament testing, all those other things we do in adults. And this is a pretty powerful tool that is easily can be done. So it's a water immersion test. And remember that fracture patterns are unique to children. What specifically are unique to children? Basically the torus and the buckling, which signifies a compressing, twisting injury. And that happens because this area right here, the periosteum, is fairly thick and tight. So that doesn't tend to fracture or snap off like in adults. And that's why we have these type of fracture patterns. And these are the torus or the buckle is associated with a force, what we call an axial force. The green stick fractures is when you have this fracture right here in the side and incomplete plastic deformation of the subsequent bone. And this signifies a bending type force, and this signifies an axial force. But because of the large periosteum, the open physis, we tend to see these fracture patterns that are unique to the pediatric population. And that's, again, our torus or buckling, green stick bowing, epiphyseal injuries, and usually you have an incomplete fracture line. And these are unique to the pediatric population. As we go to the hand, the gist of what we're talking about is hand fractures, fingertip injuries. It's very important because, in a sense, these hand fractures account for 15% of all the pediatric injuries that we tend to see are pediatric fractures. There are about 2.3% of the pediatric emergency visits, and fracture dislocations are relatively rare. So usually when children will have these fractures, if they're going to have some form of dislocation, ligamentous injury, it tends to basically go through the weakest point of the digit, and that would be through the physis, or involved into the physis in that area. And one of the things that pediatric hand, and we tend to see that the peak age tends to be in boys from 9 to 14 years old. If we looked at the data across and we kind of extrapolate, these are the typical hand injuries in this age population. The small finger tends to be the most affected. Border rays account about 75% of the phalangeal and metacarpal fractures. And one of the things that we tend to see is a lot of misdiagnosis as a result of misinterpretation of the physis and missing multiple fractures in X-ray. And what does this mean? So this right here is a normal, what we call epiphysis of the growth plate of a metacarpal. But what we tend to see sometimes in the metacarpal, we have something that's called a double epiphysis, which is a secondary growth plate, or we call it a pseudoepiphysis when you have these kind of notches on both sides, or you can have a notch epiphysis. These are normal variances, sometimes are misinterpreted as fractures. And they do not necessarily, they close about the 6-7 years of age, these pseudoepiphysis or notch physis or double epiphysis. The double epiphysis is usually seen in the index and the thumb, and that one may have some increased growth with a fracture when you injured it, but usually not the norm in the sense of having the increased length or growth after an injury if you have a pseudoepiphysis or a notch epiphysis. And this is how it shows in X-rays. Here's the fracture site, but if you can see here the pseudoepiphysis, the notch epiphysis, and these are all normal variants, okay? And it's definitely, you know, something that we tend to see sometimes are mistaken for X-rays or for fractures and patients being mobilized longer than they have to. This is something to be aware. And again, for anything that we do in orthopedics, you want to have multiple views, AP and lateral views, and it's helpful with the hand specifically to always obtain 3 views because you'll be able to demonstrate something that looks in one plane one way and in a different plane in the other, and that's why it happens in the finger. So you want to have the AP, the lateral, and the oblique views. And important to document because you can also demonstrate to the family the gravity of the situation or the injury that's going on. And growth plane involvement, those are things that we look for as well. For example, this is a child's x-rays at 3 months. And as you can see here, all the ossification centers are not present. As you move to 3 years of age, we can start seeing the ossification centers here. And these are meaning the secondary ossification centers. So for the phalanges, we've got 19 bones, 19 what we call tubular bones and 8 round bones. The 19 tubular bones are the phalanges and the metacarpals. And with the metacarpals, you usually have your growth plate in what we call in the epiphysis and the distal portion. And the remaining phalanges all have them in the proximal portion. And these secondary ossification centers will start closing around 14 years of age in females and about 16 years of age in adults. And the way they close is from distal to proximal, and that's constant. But the first physis to appear at secondary ossification center is on the proximal and the proximal phalanges. And then subsequent to that, but just remember for testing questions for the residents, usually these physis close from distal to proximal. And for the carpus, I know we're talking about hand, but for the carpus, you've got your capitate and your scaphoid, and the ossification centers tend to appear in a clockwise manner as we go, you know, as we age. So if you can look here, this is at 3 years and at 6. Now you start seeing the bones, the ossification centers are present, but the bones are becoming longer. And then you can see you have more carpal bones at the age of 6 compared to the age of 3 because of the secondary ossification centers. You know, they're there, they're just cartilage and we can't see. So this is at 6 years, this is at 9 years, and then by 16, 14, you start having basically closing these secondary ossification centers. And this is very important to know as you're examining your patient when you document and you examine your x-ray for you to evaluate as well. As we go for these patients, remember that the open physis are a point of inherent weakness and injury might result in premature closure and abnormal growth. We talk about the open physis, which is a good thing, is because it basically provides a potential healing, a remodeling potential that's fairly significant. When you have a closed physis, the ability to remodel is not as great when it's closed. Physeal fractures along the Salter-Harris classification, and we'll touch on that, because that Salter-Harris classification in orthopedics was described in the pediatric population in long bones, but it does translate to the smaller bones of the hand and the wrist specifically. And remember that children have a robust periosteum. That's that outer covering of the bone. It's fairly thick. It does improve stability and it improves our healing rates. And as you can see, we'll be talking about these areas of the phalanx. This area is the neck. Here's the shaft, the base, and this is the physis that we're requesting here. So one of the things about Salter-Harris classification, I do bring this up because this is how you guys can communicate with us and provide us information and kind of gives us an idea of what we're dealing with. So just a simple thing to remember with Salter is that you can kind of break it into a type 1, which is the injury along the growth plate. It's the same, and it's this type 1 right here. And a type 2, the injury extends above the growth plate, so it starts here and then kind of buckles this way, and then you usually have this metaphyseal fragment left behind. And this, we call this a Thurston-Holland fragment, but usually this is left behind in the 2. The type 3 is the L, the lower than the growth plate, and it actually goes into the joint. The type 3 are articular injuries. And then the type 4, when you have through the growth plate, above and below the growth plate, and type 5 is what we call an epiphyseal crush. Important to know that type 5 usually is the one that has the worst prognosis and amount of growth arrest that you can have. And what happens is you tend to have type 1 and type 2 early as you basically between 3 and 8, 9 years old. Once you get to 9, 10, pre-adolescent, adolescent, you tend to have these 3 and 4. And what happens is the physis starts to close. It closes in multiple areas, but once it fractures, because it's closed in one area, not in the other, the fracture pattern tends to be more involved, and those are the ones that tend to have more growth injury and growth issues, as in the type 3, 4, and then we see it in older adults, but the 5 is the worst. And so as we kind of got a baseline, we've got the exam. So these are the injuries not to miss, and this is just something that we see in our clinics on a day-to-day basis, and you guys will see in your clinics as well. We'll talk a little bit about the rotational deformity, which we talked about scissoring. You want the fingers not to scissor when you're making a fist. We'll talk a little bit about condylar and phalangeal neck fractures, pediatric gamekeepers, fingertip injuries. We'll talk about and highlight the femur fractures. This is something that we see a lot, that is missed and not necessarily within our community, but referred from other providers that could have been treated earlier, and we'll touch on that. Tendon injuries and a little bit of Burns compartment syndrome. I know it seems like a lot, but it's at least some salient points and probably, hopefully, high yield for you guys. So starting with the proximal phalanx fractures, one of the things it's the most common fracture location of all hand injuries, and it's most treated with splinting and immobilized because they have an excellent potential for remodeling. You can see this picture here on the right. This patient presented in a delayed fashion, and this is the 2-year remodeling potential. Okay, so they can remodel significantly. The biggest thing for these is, even though you may have sagittal and coronal deformities, if they have rotational deformity, then those are the ones that we tend to treat surgically because that does not tend to correct. But if you have malalignment in the plane of deformity or in the plane of motion, it's the malalignment they tend to correct remarkably. And kids are amazing at what they're able to do. So, if you see this in an old person like me, you better be opening and putting a pin or wire or something to help me with that. Minimal angulations less than 10 degree or non-displaced fractures. Once we see them one time, we do one x-ray. If it's that minimally displaced, we don't do any more x-rays after that. We just follow them clinically. That way avoid additional x-ray exposure. And they have a low rate of this redisplacement. The literature says about 6%. But the biggest thing is examining your patient, see the patient, and more likely these can be treated on. Now we move to the phalangeal base fracture. That also is something that we'll commonly see in your practice. And these usually are the most common secondary to the proximal phalanx. And they're very close to the physis, and these tend to be what we call a tight or a Salter 2 fracture, and they tend to remodel quite a bit. And we tolerate up to 25 degrees because in the coronal plane they do remodel, but you can definitely reduce it. And this is a technique that we use for reduction, and once you get them reduced, you can mobilize them in short-arm cast, and they'll have fairly quick healing. As we move from the base now to the neck. This is one that you definitely will see in your practice in a sense, and this one we see it miss a lot. The neck fractures of the proximal middle phalanges are classic pediatric injuries and rarely seen in adults. Most result from a crush injury to the finger, usually closed with a door or window. They do have the excellent remodeling potential in the corona and the sagittal plane. We used to think that they would not remodel as well. There's a new study that came out that really showed that they remodel both in the sagittal and the coronal plane. Not as much in the coronal plane, but the younger the patient, more likely this is going to remodel if it's left unreduced. We try to reduce it, and we used to think they would take a lot longer remodeling because they're away from the physis. If from what we talked about in the x-rays, the physis, if it's injured here, tends to be over at the base. And the most commonly type that we see is the type 2. In this one, definitely you see these are ones we definitely recommend for us to see early because they can be bad actors, and we want to treat them and address them early because we follow these fairly closely in our clinics between 5 and 7 days, every 5 to 7 days. And we do re-x-ray these because they really misbehave. As we move from the neck, we move to the condylar level. Condylar fractures is these paratuberosities here on the condyles. And these are very unstable. These are surgical fractures. And we see these in pre-adolescence. And this is something that they tend to rotate and they don't tend to heal as well. Usually, most of these, if we can get them reduced, it requires open reduction internal fixation. And again, this is one that was surgically referral early on. If you see it, those are the ones we want to see, and they're often unstable. For example, in this 13-year-old, this was the injury that presented. And it presented, you can see there's already healing. And this is about 4 weeks from the injury date when we saw them. And this is what we ended up doing. So the patient did remarkably well, but definitely made it a little more difficult the surgery than it needed to do because it was not diagnosed. And what was missed was that they were only looking at the lateral view and not the AP view. Again, like the picture we saw, the 3 views is very important for you guys to correlate with these injuries. One that we also see commonly is the thumb gatekeeper's pediatric injury in the pre-adolescent. And then remember that this is a Salter 3 type fracture and involves the articular surface. So this is an articular injury. So the ligament tends to be intact. It's not the same as in adults. But we tend to fix this fracture segment because it tends to rotate both in the coronal and the sagittal plane. And the more the fragment is displaced, it determines that it's more unstable. So the more likely it's going to be unstable. So less displacement, you can put them in a cast. But once they start displacing, they're going to stay displaced. They're not going to go back to undisplaced. And it's very important for us to establish joint congruity because then that requires surgical fixation. That creates stability because the ulnar collateral is attached to the fragment. But again, the ligament is stronger than the physis, so it basically is a Salter 3 type injury. So now that you guys are experts in the common pediatric finger fractures, we'll talk a little bit about tendons and soft tissue. The soft tissue does incorporate into what we call tendons and nerves. Tendon injuries, we tend to see them a lot in kids usually, and we see an uptick like in Halloween when they're carving pumpkins. That's one of the times when we see them also when they're grabbing knives from the dishwasher. That's why we tell parents, put your knives facing down instead of up because they'll grab them and we tend to see these injuries. And for here, just simple observation, you can see the normal cascade is disrupted. So this patient had this laceration here. So basically they injured their flexors of the ring and the small finger. So observation of the hand position, passive tenodesis like we talked about, this will give us suggest of the injury. Neurovascular injury should be considered, and that's when we can do the water immersion test. For example, and one of the things that is unique to the pediatric population, also in adults, is when you can distract the patient and you can actually, right here, kind of press this area. And I'm pressing the flexors. This is my 8-year-old. And you can see I'm pressing there. That's his FPL. I'm pressing deep there. And that's not there. That's the FDS. And then the FDPs. So you can examine the child away from the site of the injury, and you can see if things are connected. So sometimes we walk in, examine the patient. They're being distracted. They're in the mom's lap. And the injury's covered. And then we kind of uncover it and then just examine them away from the site. And we're able to garner some information on really what's going on. And this is something that you guys can be useful in your practice. Pediatric flexor tendon injuries are less common than adults, but they're as severe as in adults. I mean, this is the part of the grind of a hand surgeon, these injuries, because they can do well, but they also, not all of them do well. So the mechanism of injury, like we mentioned, pumpkin carving, knife use, glass accidents, often it's missed. I mean, it's not unremarkable for us to see them at 2 or 3 weeks after the injury, and parents, they might not recognize it. It's not that they're being bad parents, it's sometimes you don't even realize. I've had even my own kids where they had a fracture and I kind of blew them off. I said, you don't have a fracture. So this does happen, but definitely this is something missed. The timing, though, of repair for our flexor tendons is urgent. We say the sooner that you see it, let us know. And, really you can get up to 3 weeks in kids and you can still get a good reconstruction. But I'm telling you guys that, but we don't tell everybody 3 weeks, but we want to see it sooner than later. One thing that you'll see in your practice is the jammed finger. That can be basically presented in different types of pathology. When they say jammed finger, that occurs when the tip of the finger is compressed towards the hand, and that can injure the volar plate, your extensor mechanism, your flexor tendon, and basically that leads to that general sprain when we say a sprained finger. And a couple things that we see with jammed fingers is one is called the mallet finger or the terminal extensor injury. And this might be associated with a fracture or articular injury, but we tend to see the terminal portion of the extensor tendon rupture, and patients will present with this deformity right here. And they'll have a compensatory, we call it a swan neck deformity. And basically, this usually results from the, a flexion. You're completely extended and then rapidly flex, and it can avulse the tendon. In the pediatric patients, this type of injury, we see it in the pre-adolescent, because we see another injury that we'll talk about, which is a sigmoid fracture in younger kids. Central slip injuries is just at the PIP level, and one of the things is usually a forced flexion over that knuckle area of the PIP, and that can lead to a central band, or what we call a central slip injury, and that actually is this place right here. And these patients will have swelling of the PIP, and what we tend to do is immobilize just that joint, the PIP, and extension.
Cesar?
Yes.
So once it gets deformed, that's easy to figure out that's bad. But when we see them acutely, so they're all, bruised and swollen, and if you get an x-ray, you're not going to see a tendon injury. So what are you saying we should do here?
So very good. So because of the slide, so one of the things to examine for a central slip injury, one of the things that we do is an Elson test. So the Elson test is basically, one way to do it is you can put your two fingers together, your middle fingers, your back, and if you can see here, this should be, it's kind of floppy. When you have a central slip injury, when you put them together, this will kind of be tight. And that way we differentiate the central slip mechanism. Because with the flex finger, you're actually putting tension on your extensor mechanism, and because it's disconnected, the secondary bands on this side right here tend to pull the DIP out. So this is an easy way for us to check that. And this is called the Elson test. And the Elson test is also described where you kind of do it over the desk and you lift. It should be supple, and in a central slip injury, it'll be tight. And the mallet finger would be more of the clinical exam observation, and they won't be able to extend and they'll have to droop. At the volar plate injury, they'll have a negative Elson test, but they'll be very sore on the bottom, on the volar aspect. And and that's a good point. We should have put that on the top, in that portion. But yeah, definitely that's the best way for us to identify. And always with the initial sprain or the swelling that you have, it's good to immobilize just that joint and rest it, and then, and do the referral or reevaluate in 3 or 4 days, and then you can see, because usually if it's just the joint, the sprain, it'll go down pretty quickly, but you just have to adequately mobilize that joint, and you can leave the other joints free, and that would be the best way that you don't, and if there's any doubt, include the whole finger, do the splint, and then you can do the referral and reassess and go from there. Because, the biggest thing is not missing them, because then it requires some long-term immobilization. So for the mallet finger and the central slip. As we move from those, something we also see in our practice is basically it's the burn injuries that we tend to see. Usually it's the scald burns in younger children, flame burns as you increase in age, and the hand dorsum is typically more vulnerable. Usually putting hands into hot areas, and that will lead to these common burns. One thing we tend to see also is, parents are working out, they get their hand caught in the treadmill. That's an example of that, and I do have a case example of that. The initial management includes cooling of the burn hand with cold water, at least for 20 minutes, just cleansing, control with regular Tylenol, and then early referral, especially for the hand. Those are ones we want to see early. This is, for example, a patient I treated, 23-month-old patient. She got her hand caught under a treadmill while the mom was running earlier that day, and this is how she presented. And you can see here we have 2nd and 3rd degree burns and 4th degree burns in some areas, but mainly is 2nd and 3rd degree. And this right here, as we went, the severity of it, this is the extent of it went into the tendon, and this is the exposed nerve right here. And what we did with the breed, these are full thickness grafts that we took from the groin. And this right here is the patient at 6 months, and you can see all the hypertrophic scar that had formed. And then after 6 months, we went ahead and then did a full thickness repeat graft, and then we did C-plasties to release the scar. And this is after that last procedure, the patient at 6 months later. Not perfect, but they have full grip, full extension, and the contractions have been corrected. But it can be pretty profound. In this patient, we saw acutely, but a subset of this is unremarkable, the delayed presentation that we can see. Because it's so any of concern with burn injuries, really in the pediatric population, we would want to see early on. One that I will mention is the hand compartment, because I've seen this also missed. And one of the things, if you see multiple fractures in the hand, not only in the phalanges, but also at the metacarpal level, you should have a high index of suspicion of possibility of hand compartment syndrome. And what happens, what we tell our residents and our fellows is instead of you look at your hand from the side, usually you have a concavity here, but once you have that convex palm, that is hand compartment until proven otherwise. And you can see you'll have this type of swelling. Okay? And those are things to look at and to diagnose, and they just have a high index of suspicion for the severity of the injury. And remember, in the pediatric compartment syndrome patient, it's not the 5 Ps that we see in adult, it's more increased analgesic requirement, anxiety, agitation. So these patients will be restless, they'll be anxious, they'll require more pain management, more medication, and usually it's not typically of what we see in adults, and this is something very important to not miss. We're almost there. The distal phalanx fracture tip amputation is just a couple of things of importance. The distal phalanx is also in the younger patients, toddlers, they tend to use their hands to navigate. So you'll see a lot of these distal phalanx injuries, and they can be displaced, non-displaced, or you can have the mallet or the femur type that we'll talk about. And usually splinting non-op and non-operative, and you can splint them. But with regards to the femur fracture, which is a distal phalanx, this is one of the most common things that we see that are missed. It tends to be a Salter 1 or 2 distal phalanx fracture, and it's an injury through the distal phalanx growth plate. And it's an open fracture, so it's more of a surgical emergency. And the high likelihood of infection if it's missed, and certainly then if left untreated, they're going to have a nail deformity. That's different than the mallet injury, where the injury is over here on the terminal extensor tendon and involves the joint. And the femur fracture does result from hyperflexion and presents as if you were to look from the outside, as a mallet type injury. But what happened here is the nail plates avulse, it comes in, and usually they'll present delayed, and that's already healed, and you can't realize that it's the avulsed eponychial fold or the nail plate above it. And that can have that interposed tissue within the fracture site, and if not treated, like we mentioned, infection, but can lead to osteomyelitis. So what's the difference? The mallet fracture tends to involve the joint, like we talked about in pre-adolescent kids. We see it as the terminal extensor tendon. The femur variant is the distal phalanx. This is the physis, how it normally should look. When you have a femur type injury, it's just subtle widening that you can have. And those are things to consider. That's that difference. And remember that the femur variant, the femodistal phalanx fracture, is an open injury. And we don't only see it in the fingers, we see it in the toes. It's very commonly as well. That's where initially Cesar described it. And you can see this is a case example of a patient with this type of injury, open through the physis, and once you open it, you can see the severity of the injury. And these are subsequent sequelae that you can have if not treated and missed. And again, you can also, don't forget to, and if you see a bumped toe, consider this, do x-ray and look for this, because this is also commonly seen. And remember, it's an open fracture, so some that needs to be addressed and treated accordingly because of the risk of infection. One thing but not least, as we're talking the distal aspects of the hand, distal digital amputations is one of the most commonly, also aside from the proximal phalanx, but also the fingertip injuries. And amputations distal to the DRP joint can be treated with reattachment. We don't always have to do microvascular anastomosis. So if they come in with the part, please send them with the part, because there's a lot that we can do with the part. So, and usually healing by secondary intention. So even we put it, and I have a case of sample so you guys can see how kids are remarkable. So one of the things is, because if you can do an amputation, you can revise it later. We don't always have to do it acutely. For example, this is a patient that presented where the tip was reattached, And you can see this was all completely off, and you can see here as the progression, you're saying, well, this is not going to do too well, this is not going to make it. And look right here, at 6 months, look at that. So there's no reattachment that we can do better than that. So with these, we let heal a lot by secondary intention. You just have to advise the parents, let them know what to expect. And we show them these pictures, because they kind of say, what in the world are you guys doing? And a lot of them, we just put them in a total contact cast so they don't look at the finger. We just cover all the fingers. But the older kids don't always tolerate this, so that's one of the things. Case example, 10-year-old was brought to your office because he got bleeding right ring finger, and this is how you'll see it, and this is how they'll present. They have this type of injury. Here, again, what you need to note is the Volz eponychial fold, the Volz nail plate from the eponychial fold. This is what we would consider a femur fracture. The fingertip is flexed. It's not a mallet. It's that femur fracture variant, fracture through the physis, and it doesn't straighten. When you ask them to straighten, they won't straighten the finger. And again, this is what the x-rays look. This is a little more exaggerated, but usually they can have just subtle widening of that distal physis. And again, you have that apex dorsal angulation. And this was what was done. It was lifted. The eponychium the physis was reduced. Sometimes we put a wire through that area to stabilize it. Sometimes we don't. And then everything gets repaired and cleaned. And we provide an antibiotic. So I do have a couple questions just to kind of review, but do you guys have any questions so far? I know we covered a lot of material, but hopefully hit some salient points.
One thing you said way at the very beginning, you mentioned clavicular fractures, and I usually think those are accidental typically, but you said the middle third can be concerning for abuse. Tell me about that.
It can be. I mean, don't quote me on the literature, but that's one of the things, just because we see it with brachial plexus injuries, and we see it with pull type injuries. That's why we associate it.
Okay.
But definitely the middle third is not uncommon for us to associate. And that it's just a highlight. It's not the typical that they talk about proximal humerus or mid-shaft femur, but it's something that the point is that always have that in the back of your mind, because you guys will be the only, or we would be the only ones seeing that patient and have that opportunity.
10-year-old with that Seymour fracture, I'm seeing him in the office. I can just say, I look at that and I say, boy, that needs a hand surgeon. I don't know what, I can x-ray it, or do I just send it to you, or send him to the ER? I mean, I just soon send him to you so you can say, hey, wow, that needs overtime on, but.
Yeah, we would see them in the office.
Yeah.
And then we can coordinate. A lot of these, sometimes if they're pre-adolescent, we actually do this under local. We numb the finger, and we have the instruments. We have a procedure room at ION where we do that. If they tolerate it, you just put a finger tourniquet, and we're able to do that. And if not, then we coordinate to do it. That way they don't have to go to the emergency department, and it's something. The biggest thing is with the Seymour fractures is that you can have a fairly quick, robust healing. So they'll avulse, come back down, and the what we call the eponychial fold will look normal or just look kind of bruised, or they may be draining. They may have some pus underneath the skin. And then, and that's one of the things with the picture that I have, that it may look like nothing happened, but if you have that in the back of the mind, then correlated with the X-ray, then you're more likely to see it. And so one of the questions I have is just to kind of review the Salter-Harris classification, and one of these, it asks the pediatric fractures that range in severity according to their potential growth disturbance. So which subtype would be most likely to impair bone growth? They all can, but which one would be the highest that would be associated with impaired growth? Perfect. So here, again, to review, the Salter mnemonic, that basically is the 5, because again, it tends to be crushing of that physis. And again, older patients tend to have 3 and 4, younger patients tend to have 1 or 2. So differentiating Seymour fractures from mallet injury type fractures of the distal fascia is important. What is the most significant difference between these 2 injuries to the distal fascia of the hand? I'll read it. I know it's kind of wordy. Seymour fractures tend to involve the terminal flexor tendon. Mallet injury tend to involve the terminal extensor tendon. Well, the mallet does involve the extension tendon mechanism, but the femur does not involve the flexor, so that doesn't seem consistent. Femur fractures are considered an open fracture of the distal phalanx, while the mallet injury fractures are not. Okay, so that looks promising. Femur fractures, but not mallet injuries. Fractures commonly present in a delayed fashion to the hand specialist. Both can be, not only one or the other. Femur fractures do not injure the growth plate of the distal phalanx, while the mallet type injuries fractures tend to disrupt the eponychial fold. Well, with the femur fractures, they do involve the growth plate, and they tend to disrupt the eponychial fold, not necessarily the mallet injuries. So which would be the best answer? Perfect. You guys can listen. It's good. And again, just to kind of reiterate, look at this, the physis on the lateral view, you can see the opening, and it can be subtle. But one of the things is, this is the severity of the injury. You can see, look at the finger, how it presented to the office, and this is the injury it had. So this is across the physis right here, okay? So this to here, so that's significant. And it's impressive how kids start healing and kind of cover the injury. And this is after the repair. This is done by a colleague of mine, good friend of mine. He provided me the pictures. So a 3-year-old boy comes into the pediatrician's office with a deep palmar laceration to the right small finger across the proximal phalangeal crease, trying to grab a knife from a dishwasher. What would be the best way to assess if he has injured the digital nerves of the right small finger? We can ask some others. He thinks perform a 2-point static dynamic discrimination with a paper clip of a small finger. He's 3 years old. Perform a Weinstein monofilament testing. That's a monofilament test that we have in the office. It's the little filaments that we put at the end tips of the fingers, and then they're graded, and we can kind of tell if the sensory disturbance is taken. Or perform a water immersion test.
Cesar, how long do you have to soak them in the water before it begins to wrinkle?
2 to 3 minutes.
Just 2 to 3
Yeah,
minutes.
as you start seeing the others to start wrinkle, that usually is what we use. Some may take longer, but just do a warm water and just let them go play, distract, see other patient, come back, and just enough that they start wrinkling. And it varies, but usually it's 2 to 3 minutes, 5 minutes, it varies, but you'll start seeing the wrinkling pretty quick on the other. And it's pretty remarkable to see the difference. And again, to show the difference, it's the shiny, it's not wrinkling at all, and you want to have this wrinkling effect.
We have a question with that.
Yes.
Dr. Pryor is saying for the Seymour fracture, is next day in the ortho practice okay, or do I need to get them there the same day?
The next day is okay. These are my references. Thank you, guys.
I want to go back to the sprains again, because that's so common, just at daily life. People walk up to you, oh, go ahead, do my finger, When do we need to consider x-raying, or is it, when it's acutely injured, it's swollen, it's painful, it's hard to examine, and especially with children, you may not see a fracture until it begins to heal, right?
Yes.
So I think what I hear you say is maybe we immobilize and re-examine.
Yes. Yeah, but it's also good if you have enough swelling and enough bruising or skin changes to x-ray as well.
Okay.
Because you have a baseline. And then once you have that x-ray, you don't necessarily need to repeat the x-ray, but then re-examine it. And then working on your differential. Because sometimes, let's say I didn't show because of the extent of what we're trying to cover, you may have what we call a volar plate injury, which is in the volar aspect of the PIP joint of the PIP, and they may have a little fleck of bone in that area. And that's something that just signifies that, so then it's a different type of immobilization. We use those, we start actively extending, but we tell them to avoid hyperextension because they'll stretch that volar plate on the bottom. So that's a different type of immobilization. But the biggest thing is, if it's swollen, then, split and reassess 3 or 4 days, and if it's just a normal sprain, they'll start moving and they'll start using, and the swelling will start going down once they start using.
Are any of these, so the injuries that were discussed, are any of them like same day, like as soon as you see it, it call a hand surgeon and just get it fixed? Does that make sense? Like nerve injuries and,
So, you know, for these, especially for this open fracture, it was a great question. Those we want to see fairly quick. If it's not the same day, at least the next 2 days. Especially for some of these fractures that you see, like the condylar fractures and different things. Those, the sooner we see them, the better. But it's, you know, if it's in the afternoon, we can see them in the morning. Unless you see open injuries or cuts or different things, those more likely we would want to see the same day. But at least it's just to have it on the radar that you can communicate, hey, this is what we're thinking, and then, you know, and we, you know, we're here to see off what you guys sent. I mean, that's part of the, hopefully the dynamic approach that we can provide that service, and also consult or say, if you have a doubt, you can always call, ask, and say, look, this would not be the, we can treat this not, but yeah, the sooner we see them especially for those open injuries and the sooner the better. And if it's a nerve injury or a flexor tendon, if they tell you 2 or 3 days, it's still not unreasonable because we still have a window. And a lot of these, you know, once we get into the pre-adolescent, adolescent kids, we're doing a lot of these under local if the kids are able to tolerate. It's amazing what we're able to do, and then we can assess our repair with them awake and everything. So that really has changed. And COVID has pushed us to the limit doing those things. It's, yeah, even in our clinics, we're doing carpal tunnels, trigger fingers, Decker veins. We're doing on their local in our office. So it really changed our practice.
Do you have a good internet site that's a great reference? Like I found in adults that Orthobullets is one of my go-tos. Do you have something like that with pediatric hands or pediatric ortho injuries?
I can give you the information. We do use Orthobullets. We use basically the Hand Society. There's a website. It's the SSH, American Society for Surgery of the Hand. They have a good, you know, reference site. This, you know, those are the two main ones that we use, and another one that is also used is Eaton Hand, EATON, and that one also has a lot of examples and questions, and it'll help with it's a good resource. Great question. Well, thank you guys.
Thank you so much.